So next topic is gastric outlet obstruction. Okay, what is BOO? Day before yesterday we were talking about something. BOO. Prostate causes BOO. Prostatic enlargement causes BOO.
Bladder outlet.
Yeah, bladder outlet obstruction. Yeah, very good. So gastric outlet obstruction is nothing but this is the gastric, this is the duodenum, this is the gastroduodenal junction. Here, if some outlet, if the outlet, this is the outlet, right? If the outlet closes because of ulcer cicatrization or because of a foreign body, whatever, because of extensive compression, malignancy, anything, if this closes, then the symptoms will be of gastric outlet obstruction. So you should tell me, what will be the symptoms of gastric outlet obstruction? There is an outlet obstruction. Whatever you eat, what will happen?
Regurgitation would happen.
Before, yeah, regurgitation and
Reflux.
Reflux, regurgitation. Okay, better term.
Vomiting.
MSS. Yeah, he will have, because here there is an obstruction, he will have profuse vomitings. Okay, and what will go in vomit? What will be there? Along
Electrolytes.
Yeah, along with food, some electrolytes and even
acid.
Acid also will go out. HCl will go out. Okay. So see, electrolyte imbalance is like hypokalemia, hyponatremia, hypochloremia, hypocalcemia. Everything is hypo. Okay. So whatever, the patient will have severe electrolyte disturbances, severe electrolyte discrepancies. Okay. And there will be metabolic alkalosis because acid is going out. The patient will be in alkalosis. Clear?
Yes, sir.
Easy way to just, I am telling in the easiest way, just because the patient is vomiting acid, his body will be turning into alkali. He will be turning into metabolic alkalosis. And as the body is turning into alkalosis, kidney will try to, what should the kidney do normally?
Compensatory mechanism.
Yeah, it should compensate. It should not excrete acid, right? It should compensate and it should send the alkali out. But here what happens? The kidney will send the acid out. So it is known as paradoxical aciduria. Normally it should send alkalis are outside because the body is full of alkalis. Clear?
Yes, sir.
Okay. So why this aciduria, paradoxical aciduria? I'll tell you. But before that, once again, for those who do not understand, I'm just repeating. Gastric outlet obstruction, patient is vomiting hydrochloric acid outside. So he will have alkalosis. Okay, he will have alkalosis, metabolic alkalosis. But the kidney should have alkaluria because the body is full of alkali now. He should have alkaluria, but the kidneys are excreting acid. So it is known as paradoxical aciduria. Okay, the reason is, see here, because of dehydration, a phase of sodium retention, potassium and hydrogen are excreted in preference. Okay, because there is also dehydration, the kidneys think that we should not excrete alkali because there is dehydration also. So they will preferentially they will wash away potassium and hydrogen. So the patient will have aciduria. It will even worsen the situation. Okay. Yes. No.
Yes,
Sorry.
I just wanted to see the slide.
Yeah. Okay. Because of dehydration, also because of dehydration accompanying, the situation will change. The kidneys will act in a different way. They will start excreting acid instead of alkali. They should start excreting acid. Okay.
Okay, sir.
Okay, sir.
Yeah. Yeah. Before this, so you are sitting in your OPD. A patient comes with gastric outlet obstruction. What you will do? A patient is having profuse vomiting, electrolyte disturbances are there. What you will do?
Fluid resuscitation.
Very good. Which fluid?
NS.
Normal saline.
Okay, normal saline you'll give. Okay, along with that, any other thing? He's also having
Potassium as well.
International.
Potassium as well.
yeah, that is important. You should give because hypokalemia will lead to cardiac arrest. Okay, so you have to resuscitate with NS with potassium supplements. Very good. Then what you will do? This is the
Reduce
emergency. You are a
gastric
house surgeon.
acidity.
You are like you have finished house surgery, but just I'm telling you, your junior is there. What you will advise to him?
PPI,
Sorry,
PPI and antiemetic.
PPI antiemetic. Okay. Before that, one emergency procedure you'll do there only in the casualty.
Vagotomy.
Catheter.
Not catheter. Urine output for urine output sake you put a catheter. That's okay. Not vagotomy.
Jejunum.
Emergency. I'm telling. You put a some tube.
Jejunum tube.
Trials tube.
Yeah, very good. You should put a Riles tube. Why? Immediate.
To
This is
prevent
emergency. You just
aspiration.
put a Riles tube inside. Riles tube is nasogastric or nasojejunal or nasoduodenal tube. You'll just put the tube through the nose into the abdomen and just aspirate. Whatever food material is there, you have to aspirate it. Why is it so?
To prevent aspiration.
Very good. Excellent. So, if the stomach contents are increasing because of outlet obstruction and the patient is not, if he vomits, it's okay. And sometimes what happens is they will become unconscious and they will aspirate the food into their lungs. Okay. This will cause aspiration pneumonitis and death. Okay. So, immediately we'll put a Riles tube and we'll start aspirating the food material. Clear? That is the first thing to do. Fluid of choice is NS when potassium supplements, and surgery in gastric outlet obstruction. You have to do a what is this TVGJ?
Truncal
vagotomy.
vagotomy and
Gastrojejunum.
Gastrojejunectomy.
Okay. So I am telling you, okay, we'll just do TV, truncal vagotomy, because the patient is having outlet obstruction and there is an outlet obstruction is something was there. So an ulcer got psychiatrist. So we'll do a truncal vagotomy. We'll just cut the nerve supply to the stomach so that there will be no pain and there will be the gastric. The patient will have no pain, right? So why to do a GJ? That is a gastrojejunostomy. Why to do it?
Because certain parts will be resected, right? Just a small amount.
No,
Necrosis.
no.
Mm.
This is the stomach. This is the duodenum. This is the jejunum. So what I am telling is the patient we are doing truncal vagotomy. That is the vagus nerve will be there. Anterior and posterior nerves are there. I am resecting the vagus nerves. Okay, I am cutting off the vagus nerves completely. Once I cut off the vagus nerves, the patient will not have any ulcer recurrence. Okay, so why we will do a GJ? It is enough to do a DV like truncal vagotomy.
Because the absorption is not.
Peristalsis.
Yeah, you're bypassing the duodenum. So,
Yeah, I am bypassing the duodenum. I'll just anastomosis here. I'll do a GJ. Why I am asking? I'm bypassing everything. Yeah, correct. But why?
yeah, because of the obstruction, right? The
To
GO.
drain the food.
Peristalsis
There is some
of
obstruction. Okay, even if I take off that obstruction also, I will do a bypass. Yeah, good. If obstruction is there, it's okay. But even obstruction is there, so I'll take it off. But again, I will do a truncal vagotomy and a gastrojejunostomy. Why is? Because once you cut the vagal supply, nerve supply to the stomach, okay, the stomach will not be able to propulse the contents below. Am I
Yes,
drain the food.
got it, sir. Yeah.
okay? Got it. So once you cut
Yeah,
off the nerve
got it,
supply, the stomach will not be emptying the contents. Okay, because the pylorus will not open. The pylorus is closed. The vagus should be there for the pylorus to open. So you have to do some drainage procedure. We call it as a drainage procedure. So we just do a gastrojejunostomy so that even if the pylorus doesn't open, the patient will have no obstruction to the food he takes. Okay.
Okay, sir.
Okay, sir.
Okay. Just these are like MCQs. Most common cause of death in peptic ulcer disease, it is bleeding. Nothing much to explain, just bleeding. Most common complication of gastric ulcer is perforation. Most common complication of duodenal ulcer is bleeding. Which artery?
Gastroduodenum.
Yeah, I am asking it. multiple times because this is very important. And most
Okay.
common complication requiring surgery is also bleeding. Most common complication is DU. Most common complication requiring surgery is also bleeding. Complication with highest mortality is perforation. Okay, once it perforates, because the patient will have Hippocratic basis, and that is the reason why this has highest mortality. Okay, and deformities in stomach is the patient will have teapot or hourglass. Hourglass, you know, right?
Yes, sir.
This is the hourglass. Yeah. At this point, suppose see, this is the stomach. If the patient has an ulcer here, so above it will be like this. In between it will be closed. Again it will be like this. So it will have a teapot deformity or a hourglass deformity. Okay. So a slight deviation from our topic. So other type of ulcers, we discussed about gastric ulcer and duodenal ulcer. These are questions once they were asked. What is Cushing ulcer? Cushing ulcer is a special type of ulcers in which are seen in head injury patient. Cushing ulcer. Cushing ulcer. Whereas curling ulcer, it is seen in burns patient. Curling ulcer. I used to remember Cushing, C-U-S-H, Cush. There is some trauma, head injury. Curl, C-U-R-L. R for burns also, R is there, B-U-R-N-S, burns. So I used to remember like that. Curling ulcer is burns, Cushing ulcer is head trauma. Okay? Remember these two things. There are some fancy names to ulcer, so you have to remember them. Cushing ulcer, head injury. Curling ulcer in burns. And Cameroon ulcer in sliding hernia. Morning we have seen, right? In sliding hernia, there is a Cameroon ulcer. What is sliding hernia?
Gastroesophageal junction protrude.
Yeah. What is the other hernia you know of? Hiatal hernia. You know?
Rolling.
Rolling or
Rolling or paraesophageal.
paraesophageal ulcer. This is the vagus nerve. Anatomy they'll discuss again. I think vagus nerve, anterior vagus, posterior vagus. Okay. This see the vagus, it is coming down and it is supplying the pylorus. If you cut it off here, truncal vagotomy, if you are cutting it off here, the pylorus will go into spasm, pylorus spasm. So you have to do what do you have to do? What do you have to do?
Gastrojejunostomy.
Yeah, what is that procedure known as?
Billroth.
No. It is basically it is known as Billroth 1, but basically simple thing it is known as a drainage procedure. Okay, drainage procedure. Yes.
Yes, sir.
Okay, sir.
Okay. So nowadays, to overcome the problem of this truncal vagotomy, dividing the truncal vagotomy, they have modified. They have devised this technique, HSV. This is highly selective vagotomy. Highly selective vagotomy. Here, what you do is you select only a few branches. See here, this is the vagus nerve. You select these branches and you divide. Where the ulcer is there, only those branches you divide. Don't divide the entire trunk. Don't divide the entire nerve. Okay. So only the gastric branches are divided. Then, is there a need for drainage?
No need.
No need of drainage. Yeah. But there is always a problem of reference. So this is also known as parietal cell vagotomy. Parietal cell is the cell which secretes gastric acid. So you are doing that microvascular, like only the parietal cell you are doing vagotomy. Parietal cell vagotomy it is known as. Okay. Yes.
Okay, sir.
So in this case, we won't be doing gastrojejunostomy.
No need. Because there is no pylorus spasm. If pylorus spasm is there, then only the food cannot enter below. So here you do just selective vagotomy you can do.
Got it.
Yeah. And problems of GJ, there will be malabsorption. Malabsorption like iron, calcium, vitamin B12, malabsorption will be there. Once you resect some part of the bowel, there will be always problems of malnutrition. This Doop syndromes are negative. Okay. What is this H. pylori?
Helicobacter pylori.
What is that?
Bacteria.
Yeah.
Gram-negative.
Why is it important to us?
Causes
studying
gastritis.
Group
Yeah.
B.
It is a gram-negative cocobacilli, and it has a special gene called CAG-A, CAG-A gene. It causes even the gastric cancer also. Okay, CAG-A gene is gastric cancer. What is the investigation of choice? Is rapid urease test. These are organisms which will be urea positive. Urea is positive. Okay. So
Urea
I think in
breath test.
microbiology they'll discuss all these things. But for completion's sake, investigation of choice is rapid urease test. Non-invasive you have to put some tube inside the mouth. You have to do an endoscopy, and then you can do this rapid urease test. Investigation of choice for non-invasive method is ELISA. Investigation to look for eradication. That is, you give some proton pump inhibitors, you give clarithromycin antibiotics, and afterwards, if you want to see whether it is there or not, you should do a breath test. Carbon 13 urea breath test. If you just do that, you will know whether it is present or eradicated. And gold standard test is culture. And culture use silver stary stain, Jamesa stain, and Warthin stary stain. These are some stains. Okay. Microbiology, done, not done?
Done,
Done,
sir.
sir.
Yeah, I think these stains you got there, you studied there.
Yes, sir.
Yes, we did.
Yeah. So this is just an extension. Okay. So we in our from surgery point of view, you should remember this gene which will cause distal gastric cancer. And the investigation of choice is rapid urease test, RUT. Okay. So whenever you see some endoscopy going on, that person who does endoscopy will always write RUT negative or RUT positive in the end. Okay, if you see any endoscopy report, it will be there. That is, he will do a rapid urease test inside. So if it is positive, that means that the patient will have
H. pylori infection.
Yeah, H. pylori infection. What are the various diseases caused because of this bacteria? Maltoma, peptic ulcer disease, distal gastric cancer, Meniere's disease, type B gastritis. Not A, it is type B gastritis. Okay. So these are the various diseases caused by Helicobacter pylori. But see this Maltoma, 100%. The only disease which is caused 100% by Helicobacter pylori. The rest of them, what did I mean by this? 100% Maltoma is caused by H. pylori. The rest are not 100%. What did I mean by that?
Because they can also occur due to other reasons.
Very good. Yeah, it can occur due to other reasons. Peptic ulcer, it can occur due to hypersecretion, hyposecretion. 100 reasons are there. But this Maltoma only by H. pylori. This is the question for us. Sir, this H. pylori alone can cause which of the following? Maltoma, peptic ulcer disease, distal gastric cancer, like that they'll give it to you. You have to understand that alone, the word alone, no other thing, no other reason is for Maltoma. Okay.